Today's episode focuses on maternal health and is a part of a multi-episode series on this topic. Specifically, we will be talking about maternal physical health. This episode is tailored for pediatric occupational therapy practitioners, but can be helpful for any occupational therapy providers or other therapy providers. All of us here at Pediatric Pioneers want to use this platform to make a difference in maternal health. Welcome to Pediatric Pioneers, a MedBridge podcast where we conquer challenging topics for the pediatric therapist through conversations with pioneers who have blazed new trails in our practice. Our aim is to deliver actionable takeaways for practitioners like you. To receive continuing education credit for this episode and access bonus resources, make sure you check out medbridge.com. Hello, I'm your host, Nicole Quint, and I'm an occupational therapist with over 20 years of experience in practice and academia, specializing in pediatric practice and the improvement of occupational participation and performance through my expertise on executive function, visual perception, social-emotional learning, sleep, and sensory processing. It is my passion to support pediatric therapists like you so that you can best serve the families under your care with evidence-based practice solutions, easy-to-implement advocacy approaches, and new ways to lean into your skills within the challenging pediatric landscape. Today, I'm excited to be joined by Dr. Zesarae Bodie, an expert in the areas of women's health and sexual health. And for today, we are looking at the role of OT in addressing maternal health, specifically the physical aspects. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome, Zesarae.
Thank you.
Could you get us started by sharing a little bit more about yourself and how you became interested and involved with addressing physical maternal health concerns?
Yeah, definitely. So I sort of fell into it. So I was a home health occupational therapist in Manhattan, so walking around all day. And I primarily worked with older adults. And so one day I got a referral for a lady, I believe she's about 41, which was odd. And it just said weakness. And so I called, whatnot, and found out that she had just given birth. So I showed up at the home, and she was about 5 to 6 weeks out, and she had also had a C-section.
Hmm.
So she had a 3-year-old, but she had used a surrogate. So this was her first baby that she had given birth to. So she had a 3-year-old, and she had this new baby, and her partner, her husband, had returned to work full time. And she lived in a 2-story walk up. So had to take stairs up and down, no elevator. And so she was struggling with the baby and the toddler. And I was like, "Oh, wow, she just had a baby." I've never worked, and I realized, like, in all my years at that time, I think it was maybe, like, 8 years in, I had never worked with anybody who was pregnant and or had given birth. And I felt a little out of place because I was like, "Wait, nobody taught me what I'm supposed to do." And so that's sorta how I got interested in the topic. I mean, we had a great, episode of care. She felt like we helped, working on, the things that she was struggling with, but it was like, oh, wow, we really need to talk about this a little bit more so that people don't feel caught off guard when they get such referrals.
Yeah, and I think, this is such an interesting topic. This is part of a series. We've been talking about maternal mental health. We've been talking about preeclampsia. But I think it's easy to forget that when women go through pregnancy and they have a baby, it's a pretty intense physical change that they then need to recover from.
Right.
And
Hmm.
that recovery could hit some hurdles.
Yes.
Right? And then I
Hmm.
think we've talked a little bit too about how the moms are so focused on their role of being a mother
Hmm.
and the occupations taking care of the baby that sometimes they kind of forget to take care of themselves. And I
Definitely.
think sometimes healthcare practitioners forget about that maybe too. right?
Definitely, yeah, and like you said, thankfully, now we are talking a little bit more about that emotional side, that mental health recovery that moms go through, right?
Mhm,
But like you said, we're still not adequately addressing the physical side, especially when you have a traumatic birth, right? Or
mhm, mhm.
C-sections, right? Because you're not thinking about what's happening to the muscles, the joints. A C-section, your organs get shifted, your nerves get stretched, your muscles get cut sometimes. And, the typical standard is like 2 weeks out, they check, make sure everything's healing. And then you don't come back for 6 weeks and then that's it. Right. And so, you know, even without the C-section, just a typical pregnancy, right? Your body is going through so much, right? It's
Mhm.
like I like to liken it to like it's like a athlete, right? It's your squatting, you're carrying, it's like Iron Man, right? All while healing and trying to adjust to these major changes and how your body feels. And then when you think about the fact that you couple in um, like lack of rest, lack of sleep, right? So that's impairing your cognition and increasing your stress, anxiety. And like you mentioned, the focus a lot of times is on the baby. So you're pushing all this aside just to make sure that you're keeping this little one alive. And then your body is taking the toll. And we're really not asking the right questions.
So I think it's interesting, and this, maybe I'm being dramatic, but I think that a C-section, we need to start talking about it as a surgery.
Hmm.
You had surgery if you had a C-section.
Hmm.
But I think we tend to just say, "Oh, you had a C-section," like it's like option B,
Right. Like it's
right?
something different. Yeah. Hmm.
And instead of saying you had a C-section surgery. So I
Hmm.
almost feel like if we add that word onto C-section, we think about the recovery differently. But when I've had surgery in the past, you know what I did? I went home and laid on the couch for a while,
Right. Exactly.
right? When I had wrist surgery, it was like, okay, I had to kind of take a step back,
Mhm.
be calm, rest. I'm on pain meds, you
Right.
know,
No, you were
but
recovering.
I
And
didn't
you
have
should.
a baby who needed 24/7 care,
Yep,
right?
and then you couple that, like you said, what if you don't have that support system or that family or that
Mm.
circle and you have other kids, right? Again, it's almost like it's normalized, like you said, like, "Oh, you had a C-section. All right, see you in a bit."
Right,
Versus
right.
like a true surgery where there's like actual scheduled follow-ups that are like regular check-ins and whatnot. So definitely.
Mhm. So, we've kind of prefaced this by framing it as some people had C-section surgery, there's a lot of physical changes, but I want to really ask you, why is it important to discuss the physical concerns that women face during and after pregnancy? We're talking here primarily to pediatric OTs and OTAs who are going potentially in the home or working with families in early intervention. And so they're seeing some of these moms who are in this physical recovery, but they're being referred to therapy most likely for the baby. So I
Mhm.
wanted to kind of get to that idea of why is this important and why are we reframing this for our pediatric therapists and others who potentially work with pregnant recovering moms or just moms that have just given birth.
Yeah, definitely. So like you said, a lot of times the therapist that is in the home is there for the child.
Mhm.
But even um, we know that there's a link between maternal health and infant health, right? If the mom's healthy, they're able to provide better care for the child. And research shows that within the first 1,000 days of a child's life, if they have good health outcomes or good care, it leads to better physical, social, and emotional cognition, well-being later on, right? And we talk about it a little bit in therapy, and we all are all introduced to it as occupational therapists, the notion of co-occupations.
Mhm.
And, it truly, I mean, there is no more obvious co-occupation than the interaction between a mother and child, right? So that co-occupation is that shared experience between two individuals. So if you think of occupation that requires two people. The actions of one individual is going to naturally shape how the other one performs. And this is so integral and important when we're thinking about those critical times of childhood development. And that's going to help that child reach advanced levels and be able to develop into future occupations like play, emotional regulation, etc. So um, you really can't separate the two, right? So if mom's not doing well, what if maybe you got a referral because the baby's not feeding well, but maybe mom is just uncomfortable and not able to sustain the hold of the baby, right? And so rather than looking at what's going on solely with the child, maybe it's we need to teach mom how to reposition or work on some pacing, activity pacing, and just look at what's going on in the physical environment that we can help modify to give her that that um that independence in doing the task.
Mhm.
And also, I am guilty of saying it because I've been saying it a lot even as we started, and this sort of, like, is a little bit of a tangent, but also just shifting the narrative from saying "mom," right? Because
Mhm.
mom is a person, and I
Mhm.
think that we all do it naturally. I don't think, there's no malice,
Mhm.
no ill intent, sorry, but we go in the home and we're like, "Oh, mom, how are you today?" Right? It's
Mhm.
almost like we reduced, in a sense, mom to just being mom, and so
Mhm.
I think just having that mind shift takes us away from looking at what she may need. So I think that's also, that was a little bit of a tangent, but I
But
wanted
it's
to
an
put that
important
in.
one. We had Elise Block on here. I think it was like maybe episode 6 or something like that, where she talked about patient and family engaged care. And the first principle is respect and dignity.
Mhm,
And you're supposed to ask the family what they want to be called. Do you want to be called mom? Do you want to be called
mhm,
Nicole? Do you want to be called Mrs. So and so? What do you want to be called? And so I think that's a really important point, and I'm glad that you went off on that little tangent because I do think it's like you said, it can reduce it. And listen, I'm guilty of it too. I just did it.
mhm. Right.
But I also think it almost is sort of kind of reaffirming that your focus right now is on being mom.
Yep. Mhm,
And then we're kind of making it harder for them maybe to admit this is uncomfortable.
mhm,
Admit I'm in pain.
mhm.
Admit I'm afraid to move. You just had surgery,
Right.
feeling disconnected from your body because that might you're setting yourself up to maybe admit that you're failing in the role of mom, which is already a
Mhm.
very intimidating process. So I think you're
Definitely.
right to bring that up, and I'm glad that you did.
Yeah.
And that's something that we can very easily correct,
Mhm.
right?
Yeah,
Language is
definitely.
everything.
And just like you said, and I don't wanna reduce it. I know I started, talking about C-section, but even without the C-section, you just had a baby. You know what I mean? So,
Yes.
even without the surgical component, like, your body went through something. And like you said, I think that we normalize the pain in a sense or normalize the discomfort. And so a lot of people don't feel like they have that safe space to be vulnerable and to ask the questions. Because
Mhm.
it's like, well, everybody else is doing it fine. Why am I struggling? And really, when you start to have those conversations, you realize a lot of people are struggling. We're just not talking about it as we should.
Yeah, I would imagine 99.9% are struggling because you're
Right.
not sleeping. Like you
Mhm.
said, there's pain, there's healing, there's so much going on. Plus, you're having to figure out how to take care of this new being, which is
Mhm.
terrifying.
Mhm.
So I think there's a lot here. And I think we're talking about kind of reframing our perspective. I know you and I were talking about how, so many of us grew up with people saying, oh, it's not that big of a deal. People work in the fields, give birth, and move on. And
Mhm.
we're reducing this, pregnancy and delivery to, acting like it's not a big deal.
Right.
And it's a very big physical,
Mhm.
hormonal, mental, occupational
Mhm.
transition. We need to think of it as a transition, and also thinking about how there's a lot of healing that has to go on and a
Mhm.
lot of shifting in your own kind of occupational day to day
Of course,
with
yeah.
a body that's been through. potential surgery or just a birth,
It's
which
a
is a
lot.
very intense
Mhm.
thing.
Yep,
Mhm.
definitely.
And the hospitals now having the woman who just gave birth out of the hospital quicker.
Oh,
Yeah.
yeah, definitely. Right. It's almost again, it's that normalize it's like unless something's wrong typically with baby, then
Mhm,
you're just out, right? So, yeah.
mhm.
So, yeah.
So now, if I'm back in the day when I was doing early intervention and I'm walking into a home, instead of just thinking about the baby,
Mhm.
we can shift and include the woman who just gave birth to that baby. I'm avoiding
Of
saying
course.
mom,
Mhm.
and, everything that she has gone through as well. So,
Mhm.
knowing that they had this huge physiological shift and,
Mhm.
there's healing going on, whether it's just the birth or a surgery involved, what does the recent research say? Can you give us some of the highlights, and some of
Mhm.
those important takeaways, on this
Yes.
topic?
So as I alluded to earlier, a lot more conversation around the co-occupations and how it is really important to focus on maternal health to ensure infant health, right? So that's a big one. There has been research around the importance of having strength-based approaches or interventions for mom, because helping these women to adapt during their changing roles and their bodies and what that looks like. And like we said, when we couple that with lack of sleep and increased anxiety and whatnot, there have been scoping reviews that have affirmed that OT is able to bring in that strength based, that client based approach and really have positive changes. And then we are hearing a lot more recently about pelvic health programs, right?
Mhm,
And that's OT, occupational therapy, and physical therapy, right?
mhm,
Are both shown to reduce like long term dysfunction and just speed up the recovery. So yes, maybe mom, without any intervention, would get back to normal in 6 to 9 months, but having these um, more intentional interventions can speed that up a little bit. And then also, just even when we're looking at C-sections and scar massages, though that is something that is, I wouldn't necessarily recommend it to someone that's a beginner. That might be more of a point of referral, but just
mhm,
that scar mobilization around those C-section scars can help reduce pain and pressure and eventual back problems and other pelvic issues early on. So yeah, so it's
right.
quite a bit coming out. It's not as much as I would love to see in the OT realm around like specifically physical health, but I'm sure as we continue these conversations, it will grow.
And even some of the scar massage and management from, like, an episiotomy
Mhm.
afterwards, and then, like we said earlier, that you're an expert in sexual health, so
Mhm.
that's thinking about
Right.
when they want
Mhm.
to resume intimacy
Of
to be ready
course.
for that.
Of course, because it's like the textbook right now is, oh, 6 weeks, your cervix is closed, you're good to go. Right. And honestly, that is more focused on the cervix being closed and reducing risk of infection. That has nothing to do with, like you said, if you have vaginal tear or if you're just in pain, right?
Mhm,
It doesn't consider that. And so a lot of times, in maternal health, and even when we think about that sexual health side, people aren't comfortable asking their physicians these questions, right?
mhm,
Because again, they
right.
feel like it's just something that everybody goes through and everybody gets over. And so, really opening up and giving that safe space. We know a lot of times as occupational therapists, I know just in my own practice, um, I get so much from clients and patients that they have not shared with other healthcare providers because we have that therapeutic use of self and we're able to create that space for them. And so that naturally allows them to just share more.
Mhm. Right, and I think, y when we were thinking about this, you're going in for early intervention, you have this baby that you're working with. I used to get referrals for kids that were really, a few weeks out because of heart issues and things like that, premature, they had just gotten out of the NICU. So, the woman who had just given birth was recovering still,
Hmm.
and, so I'm going in there, I might be the only person, healthcare provider, that she is
Mhm.
talking to.
Yep.
And so that's why I think this is why we want to bring this to pediatric therapists, particularly those who work in early intervention or pediatrics. Maybe she's having additional children and you're seeing the older child because
Uh-huh.
you're on the front line.
Yep.
And you're right. We often are that ear to have them talk to. And so if we open up that conversation, we can then either try to find a way that maybe we can add them into the caseload. Maybe
Mhm.
they get a referral to see us and we can see them, or we can refer them out,
Right, of
which I
course.
think is a great point, like you said.
Mhm.
You brought up a little bit too about the co-occupation piece and the
Mhm.
role of mothering. What is the research saying on that? I know earlier you talked a little bit about that.
Right. So definitely looking at the role that we play as far as um, you know, activity analysis, right? So, OTs, that's what we do, right? So,
Mhm,
looking at what is it that this person needs to be able to do this task and really breaking it down. And a lot of times when we're talking about the physical side of things, we're looking at their ability to safely lift or their ability to tolerate you know, 3 hours of doing these tasks for these multiple children, right? So that
mhm.
lifting, that endurance and whatnot. And so, um, yeah, so the research, there have been scoping reviews that do affirm that, we do have the ability to help these women adapt to their changing roles and routines and even help heal their bodies.
So, yeah, the positioning when they're bathing the child, the positioning when they're diapering, like you said, picking them up. There's so many instances where we can incorporate and think about that when we're
Hmm.
doing the co-occupation routine building,
Hmm.
which I love that. So let's talk about translating this information into practice.
Hmm.
And we've talked a little bit about reframing everyone's perspective now to consider the woman who just gave birth and
Right.
understand she's healing. She's been going through a lot. She might be healing from a surgery as well, or an episiotomy or something like that.
Hmm.
So now we're going in, but we're probably treating the child.
Hmm.
So what are some who are the patients or conditions for which this would be most appropriate? And then we'll kind of go from there.
Yeah, and so as you mentioned, those who have had an episiotomy, so someone who has had a vaginal delivery with tearing, or had to have stitches, or those who um, are experiencing because of that, like pelvic pain, cervical pain, or have that fear of movement, right? Because they don't really understand what's happening, and so the thought of moving too much and lifting, it causes fear. As we mentioned, C-section recovery patients, right? Because, a lot of people have, as I mentioned, my patient was on a second floor walk up, but what if they just live in a home that has stairs, right? So
Mhm.
stair
Right.
recovery. And again, that lifting concerns is also going to be a part of that. When you think about diastasis recti or those clients who've had that abdominal separation, right? So again, that movement, functional movement is a concern. They may have increased back pain. They might have difficulty finding comfortable feeding positions for their child. And
Mhm.
then, to take it even before then, if you happen to have a mom who was pregnant at the time and you're working with their child, maybe it's a pregnant client who still has to do all the demanding things that come into the day, right? So maybe they're still working, maybe they are, don't have that support and multiple children, right? Someone who's had previous surgeries with pregnancy or just previous surgeries that might be abdominal, lumbar, et cetera, right? Like any of those things. And really, so really and truly, I think every parent should get a screen. At
Mhm.
minimum, there should be some type of conversation around it,
Mhm.
even if you find out, oh, this person is functioning well. They're, you know, but I think, we should be asking the question of everybody, honestly.
Right. And it should be involved in that initial
Initial. Mm-hmm.
evaluation that you're doing with the child,
Mm-hmm.
bringing that in because again, it's so based on co-occupations.
Mm-hmm.
The child can't bathe it bathe
Right.
him or herself. So they
Right.
have to have the mother or the father there helping, and we need to know that information. Yeah. So,
Course.
and again, we're potentially the only one taking any of this information in.
Yeah.
So it's a great
Especially,
opportunity.
yeah, because if you think about like a standard vaginal delivery with no complications, the mom is probably not going in until about 6 weeks out,
Mm.
right? So,
Mhm.
you may get a referral before then. So, yeah, so you might be that first person that they've even had the opportunity to speak with.
Right. So, how do you see this potentially playing into a therapy session? Um, you know, when we think about this as, I mean, I don't know, is it an emerging practice area? Is it just expanding how we're doing pediatric practice to be more inclusive? However you want to look at it. Um, how do you see this going? If we're going into the therapy session, how am I, as the therapist, going to think about it and then move forward to help this woman who just gave birth?
Definitely. So standard intake, and I will put out a disclaimer. I am not a pediatric therapist, so I should put that out there. But standard intake, you are asking usually the birth history or the birth story of the child. So how much weeks gestation, what type of birth, all that good stuff.
Mhm.
But within that, just you can include a question to mom. How was it for you? Right? It might just be something as simple like that. If let's say you don't have a EMR system that like has like specific questions for mom, maybe you're just injecting those types of questions in as you go. And once when you realize what the child might be struggling with, right? You're also looking at, well, okay, mom, so how are you doing this? So when mom is picking up the baby, or I know I go to feeding a lot because it's a pretty standard one, but when you see how mom is picking up baby from the crib or the bassinet, what is her functional movement, right? So it's also just looking at the full picture. Like you're there anyway. It's not really taking any extra time. It's not, I don't think it's an expectation that you're evaluating mom, but you're
Mhm.
looking at, okay, well, as mom is doing this, is she clutching? Right? Is she wincing? Is she grimacing as she's picking up her baby? And then if she is, maybe pausing and saying, "Hey, hey," and don't say mom because I know, but I don't have a name right now. But
Right.
hey, Sarah,
Right.
I noticed as you were picking up, the child, like you seemed like you were in pain. Do you want to, what's going on? Like how? And again,
Mhm.
I think also pulling away from that clinical speak around it is also going to open up
Mm.
the floor for mom to just say, yeah, I really realize when I lift, like I'm getting some heaviness in my
Mhm.
abdominal area. So yeah, so just definitely if possible, including in that intake, how's your pain, right? Is there anything that you feel you can't do for your child, even if you want to put it that way? And then maybe asking, and then why? What do you think is stopping you? And like I said, you're already there. So looking at how the posture is, how the breathing is, right? How the lifting is, because I know even for me as a primarily adult therapist, I go in for one thing and then I watch them get out of bed and I'm like, wait, that doesn't look right. Maybe we need to figure out what's going on. So it's the same
Yeah.
thing. It's just
Right.
broadening our view and looking at mom as well,
Well,
or caregiver.
this isn't any different than what you already do,
Hmm.
except it's a different thought pattern, right? Because you are going to watch the mother or the caregiver with the child, how they're doing it. That's
Hmm.
a normal part of it. Posture,
Uh-huh.
mobility, body mechanics or transfer mechanics, lifting, breathing patterns. But now what you're thinking, I think the shift is you're not just focusing on the baby and the safety with the baby. You're saying, or even just is the mother doing proper body mechanics, because that's what we look at. You're saying
Right.
this is a mother who just gave birth, who is recovering from a very intense physical change,
Hmm.
and then also potentially a surgery.
Hmm.
So then all of a sudden, if you take it with that lens, and you think about it co-occupationally, it fits in perfectly. So I could imagine, if I was still in EI, I would be adding, co-occupation piece, checking on mom and bringing in that birth history with the functional piece,
Mhm.
is a really easy shift to do. And then also, like you said, adding the pain piece. And last episode, we talked to Patricia Corbin about preeclampsia, and she
Mhm.
emphasized over and over again checking on the preeclampsia piece and adding that in. And then if I go back to Teddy Buckner, checking on the mental health piece, because this all affects the baby.
Yep. And
So I think it's
honestly,
a
mhm.
important but easy shift.
Yeah, and I was gonna say, honestly, even all of those things are probably not gonna take you more than 10 minutes to
Right.
screen,
And
I
the
mean, yeah,
return on investment is huge.
definitely. I mean,
Huge.
obviously, if something's, wrong, it takes a little bit longer, but obviously we also
That's what we
needed
do.
to figure that out, right?
Right.
So yeah, but yeah, it's something that can be inserted just in conversation, yeah.
Mhm. So what would be some of the interventions now that I've flagged the section that said, proper body mechanics, and I'm like, "Oh boy, she's
Right.
wincing, she's in pain." She's
Mhm.
probably in pain because she just had an episiotomy or she just had a C-section
Mhm.
surgery. That's my new thing. I'm gonna add surgery
Right.
after C-section. Um, and she is in pain taking this baby out of the bassinet.
Yeah. Yeah. So, like you mentioned earlier, there's nothing that we or I am recommending that we do in this case that we don't do anyway, or that we aren't naturally trained as entry level therapists to do. Right. So, again, activity analysis, we can go back to that. Right. Like, what is the task? What is the environment? How is Sarah? So, how is Sarah getting baby or moving baby around that environment, right? So, looking, it could be environmental modification, right? So maybe it's, if the bassinet or the side of the crib is too high, maybe there's a step stool that you go so you don't have to lean over so much and put so much pressure, right? Maybe it's recommending like having the crib or the bassinet that has the cutout so that you can put it down, right? Because again, a lot of them have it, but sometimes, we get into this routine of we just want to move quickly. And so we
Mhm.
don't even think about it. And a lot of times we as therapists, I think we think that they would do that if they needed to. But sometimes people just don't even think to do it, right? And you bring in that the fact that you're not sleeping, your cognitive strengths are definitely not at 100, right?
Yes.
So it could be um, activity pacing. So,
Mhm.
they
Right.
call it, activity bundling sometimes. So,
Mhm.
looking at your day, looking at these tasks that you need to do for baby
Mhm.
and, blocking them or pairing things that, "Oh, these can all be done at the couch. So, while I'm here, let me get this done," versus having to go back and forth, right? So,
Mhm.
again, that's that
Right.
general energy conservation, activity pacing that we do anyway,
Mhm.
right? Um,
Right.
finding, um helping or facilitating like partner conversation, right? So
Mhm.
maybe it's oh, like you said, I feel like I should be doing this because I'm
Mhm.
the mom.
Right.
And maybe it's like, well, have you thought about asking for help in this area? Right. And sometimes people just need the words or people need
Right.
it's almost like you're giving them it's okay to ask for help with this. And so
Yes.
facilitating maybe those conversations. Um,
Yes.
it could be, getting up out of bed or even off the couch, like teaching those body mechanics, teaching things like log rolling, right? I don't know why after C-section surgery, especially, like that's not a part of the training before you leave the hospital, like how to move in the bed. Right. Like, so
Right.
that's something again that's quick that we can teach and looking at what that looks like when you're transitioning or if you're feeding baby on sideline because sometimes that can be a more um, comfortable way to do it and I think um, I wanna say too, if someone's not comfortable, right? Because, we're throwing all these things and it sounds great, but somebody may just be like, "I just don't feel comfortable."
Mhm.
You may just be
Sure.
a point of referral. You may
Right.
be the person to call the doctor back and say, "Hey, I'm here seeing baby. but I'm really concerned that mom would benefit from a referral to another provider for
Exactly.
XYZ.
Right.
Um, and then, the last thing I sort of skipped over this one, I talked a little bit about that diastasis recti, but teaching breathing techniques, right? So
Mhm.
really teaching mom how to go back to engaging that core, especially when lifting. So there's this it's like an exhale to move training. So it's essentially when you're about to do heavy tasks, how to engage your core. And it's through exhaling. I mean, it's more to than that, but it's exhaling to really engage those transverse abdominis muscles before you lift baby, for example.
Mhm.
So just to take some of that pressure off and then also work on strengthening those muscles. So I think, there again, nothing that I've said is, you know, out of the realm of what we do anyway. But I think almost the most important thing there is if you don't feel comfortable, that's okay. Just be that point of referral.
Right, and I think I mean, all of these things are again, you might think it's just common sense or people should
Yes.
know to do them, but that is putting way too much onus on the person, but it's
Mhm.
also devaluing what we do that is highly skilled,
Mhm.
right? And so w we are the experts in occupation. We
Yes.
are the experts in occupation hacks, environmental hacks.
Mhm.
That's what we do.
Mhm.
And people love hacks because
Of
it can
course.
be life-changing, right?
Right, no, it's true. It's
So,
true.
when I hear you saying this, I mean, these are environmental hacks to help the
Mhm.
family, not just the mother, but also
Yeah.
anybody, because maybe the helper is grandma,
Yep.
and maybe
Mhm.
grandma,
It's
we have to worry
older.
about her
Yeah.
proper body mechanics as
Uh-huh.
well, right?
Mhm.
Or Aunt Judy who's coming in. So, who knows? It takes a village, right?
Right.
And even with dad, we can't just
Mhm.
assume dad doesn't have, maybe
Issues,
dad
yeah.
works in construction.
Mhm.
So, um, so then we have these environmental hacks that we could do, these recommendations, whether it's ergonomically, like you said, or step stools or cushions, or, the having that door that comes down on the bassinet. I love that idea of the plan pacing and the occupational pacing, energy conservation, but I like the idea of plan pacing.
Mhm.
I like how you said that because I think we typically say, "Oh, we're gonna do, activity pacing or, occupational pacing, and we're gonna bundle them together." But I like how you said, "Let's do it a little bit ahead of time and plan out how we're
Mhm.
doing," because earlier you said something that I think we forget about is that there can be some anxiety or anxiousness here, and
Yep.
whenever we plan, calms that down, and
Yep.
so I like that because then I feel like you also feel a little bit more like you're in control, and so we're giving
Mhm.
the woman who just gave birth, who happens to also be mom, um,
Her name is Sarah for
her
the
name is getting
purposes
longer and longer. Um, she's now gonna feel more in control, more
Mhm.
physically like, I am taking into consideration myself. I
Right.
am taking into consideration my own safety to take care of this baby, so I really like that idea. And then, like you said, the toddler care routines, helping because a lot of times they're gonna have a three-year-old running around, and we know they're on fire. So, how do we help with that as well?
Right.
And I
Mhm.
do think, like you said, let's bring in the partner, let's bring in the other caregivers. It doesn't mean you're failing.
Right.
This is your
Mhm.
support system, and everybody wants to help. So let's
Yeah.
bring
Mhm.
them into the fold as well.
Definitely.
So I love, love, love that. So, now that we're thinking about the perspective of these occupational therapy
Mhm.
practitioners or even physical therapy practitioners going into the home, typically in the EI situation, it could be speech, PT, OT. So anybody's going in
Mhm.
there and maybe having that first point of contact. Um, what do we need to consider when it comes to the perspectives of some of the other, stakeholders that are involved in this process? So, what are some of the talking points? We already kind of talked about word choices, like maybe not just always using mom is a
Right.
good strategy. Maybe saying C-section surgery,
Right.
or other strategies that you would suggest to aid in the buy-in and carryover of what we're talking about here is a shift, this paradigm shift in practice.
Yeah, definitely. So I think, for our patients, our clients, it's going to be a lot of education, right?
Mhm.
So letting them know what we are able to do. Because I think, as occupational therapists, that's like we're constantly saying we can do that. All right. So I think it's also just educating them, even, as if you are a pediatric therapist, yes, I'm here to see baby, but I can help you with your routine to allow you to see baby more efficiently or more effectively, or get more joy out of the entire experience so it doesn't feel so much like work or a chore. Um,
Mhm.
and as I mentioned earlier, creating that space for mom to be vulnerable. So letting them know that, maybe we didn't identify anything on that first check-in, right? But maybe if things come up as baby's growing, as baby's getting heavier, as there are other
Mhm.
tasks that I need to be able to do, they know that they still have that space to come and say, hey, Nicole, now I'm struggling with XYZ.
Mhm.
Um,
Mhm.
and then ensuring that they truly, when we talk about that education, using that like teach back method. So not just saying it, but maybe walking them through it and having them show you what they're working on. Or, even if you want to give more control to mom, having her walk through the process, whatever the process is, and talking about ways that she has thought about making it easier and just sort of being that person that she can bounce ideas off of, right? Because that in itself is empowering because then mom came up with it, right? And it's like, yes, that's a great idea. Um, and then, looking at how we and educating EI providers and home health providers on how we facilitate that routines, right? And their roles within the home. And really, I think all of us as home health providers, we that that hands down is my favorite area of occupational therapy because we are able to be in their space and
Mhm.
do the things, right? And really, really showing the value to these providers that we are the ones who are helping them have this routine that's going to help them through this transition period, and really getting buy-in from that, using examples, sharing stories, right? Positive ones, but even the negative ones, right? And the negative ones are unfortunate, but sometimes it helps to really understand we could have stepped in or we could have done this. And so they know, well, now I'm going to start looking for XYZ,
Mhm.
right? And then just, as when we're thinking about providers from more of like physicians or nurse practitioners, et cetera, or even other therapists like PTs, SLPs who may not really understand what we do. Um, Talking about functional outcomes, right? Everybody knows that we want to reduce pain, right?
Mhm.
These are standards. We wanna reduce pain, we wanna have mom sleeping better, so they don't take a lot of buy-in, but
Right.
just kinda tying in how what we do, those functional outcomes will lead to that, right?
Right.
And then telling our providers, if we can handle this, if you make a referral for mom, we can handle this on the back end. They're not coming in every week with a concern or
Mhm.
with this because we are able to help manage it in the home. And I mean, I think they'll buy that just because, right?
Well, I
It's
would have loved that when I was in EI to help the mother as well. I would have
Mhm.
loved that.
Right.
What a
Mhm.
really amazing opportunity. But yeah, you're right. I mean, talking to doulas, talking to the lactation
Mhm.
consultants, there's so many opportunities here for us to really show what we do, what we know, what we're experts in.
Definitely.
And like you said, what I really like how you talked about teach back method because I think in pediatrics we don't use teach back as much because a
Right.
3-year-old's not going to teach it back to us. But adults, that
Right.
is, best practice. And
Mhm.
so that's another really important piece is, there's so much confidence and self-confidence to come from
Mhm.
teaching it back and being like, okay, I know how to do this.
Mhm.
So then you're going to be giving Sarah or the mother, this competent kind of approach to
Mhm.
navigating this new body that she's dealing with in this recovery with these new occupations that she's
Mhm.
doing. And so I think that that's huge because there's going to be confidence gained in that and then feeling like again, there's some sense of control. But I
Mhm.
also
Yeah.
think too, I like how you talked about the pain piece. Just because they said there wasn't pain that first day
Mhm.
I would revisit it every time
Yeah,
because pain is a sneaky beast. It can
it
come
sure
at any
is.
time. And these women are going through a very complicated, hormonal situation. And so their pain might be masked a little bit at the beginning.
Yeah.
The pain gates might slowly start opening up,
Mhm.
but because they said no at the beginning, it would be easy to miss that. So I
Definitely.
like how you brought that up, that we need to continue to ask and check. And, pain is an obstructionist to occupation.
Oh, definitely.
And we wanna catch that and make sure that we are addressing it.
Mhm. Mhm.
So I like how you were talking too about educating the physicians or the nurse practitioners or OBGYN offices. Would you recommend giving, like, guides and handouts to them that really kind of talk about what we can do and offering that referral? Like, you could
Yeah.
refer us to work with the mother as well?
Yeah, definitely. I mean, if you are within a bigger organization that you work
Mhm,
for, even offering to be that person that does maybe an in service or develops just a handout that, this doctor's office refers a lot of babies to us.
mhm,
So, let's go ahead and just give them some material or even because that's twofold, right? It educates the staff, but also maybe there's something in the waiting room that mom picks up while she's there, and
mhm,
she's able to sort of preemptively think, oh, maybe this is something I could use. So yeah.
mhm.
Hmm.
Yeah, and I going back earlier when you said, helping them before they get discharged from the hospital after the delivery, I that would be so amazing. Can you
Yeah.
imagine if we were part of that exit
Mhm.
process, that discharge process? And I mean, they did it for a family member I had who had surgery that was orthopedic in nature.
Right.
Why not?
Yeah.
But again, we have to advocate for these opportunities and show that we can do it how we would do it, that we're using best practice approaches, evidence-based approaches. And then what's that return on investment, right? You're preventing
Hmm.
more injuries,
Of
issues
course.
down the road.
Yeah, and
Right.
definitely after surgery, if nothing else, right?
Mhm.
After that C-section surgery, somebody should be in there saying, "This is how you would do XYZ,"
Get out
right?
of bed.
Right, right. This is how you would pick a baby. Because again,
Yes, how are you gonna pick
you
up the
don't want reopening of the incision. There's so many things that can happen, and especially when you
Mhm.
go home unprepared, if you think about like, life happens. Like, you're not sitting
Yeah,
there thinking, "I need to pause and then roll."
right.
Like, you are, like, trying to get things done. So just having the knowledge in the back of your mind is gonna help you even when you first get
Mhm.
home.
Yeah. So, I always like to ask everybody, talking maximum impact,
Mhm.
what would be your top 3 actionable takeaways that the therapist can put into practice addressing this physical health element of maternal health?
Mhm. Yeah, I think, number 1 would just be to do it.
Mm,
So, again, we know that there are, more specialized certifications like pelvic health or
mhm,
maternal health, but you don't need to wait to do those formal trainings, right?
mhm,
Use the tools that you already have. So use your tools of activity analysis, use your observational tools, use your therapeutic use of self to talk to mom, right? And use your ability to modify the home environment, the environment that these women and children are existing in, right? Energy conservation, we know that. Um, Also, we talked about infusing some of those questions into the intake, but even just, on regular check-in, like, is anything harder today? Just asking questions, just
mhm,
asking the questions. Um, Find out, what mom's rest is looking like what support mom needs when you first go. What support does she have? Right? Find out what is really hard or what might she be avoiding. And again, you can tie this back to what she's doing for the child. Like, you don't have to make it a separate thing. So yeah, and again, because remember, you're observing, so you're seeing
right,
some of these things. So you're just pulling from that information that you sort of already have. You want Sarah to say it this time, right? And then
mhm,
And then as we mentioned just a few minutes ago, advocating is going to be the most important thing. People don't know what we can do unless we tell them. I mean, point blank, right? Like, if they don't know what we can do, they're not gonna call and say, "Hey, bring in the occupational therapist," because 'cause they're like, "Well, why?" Right? So, really advocating for us to be a part of that perinatal care team, right? I mean, it's such a broader conversation. We can
Uh-huh.
go all the way back to, like, issues with trying to conceive and fertility.
Oh,
Like,
sure.
OT can be a part of this journey from beginning to end. But again, nobody's gonna call us if we don't show our value and we don't educate. So really advocating, right? And that could
Mhm.
be it doesn't always have to be formal, like on a big stage or anything like that. It could be
No.
casual conversations because you never know who you may be in the room with, and that can lead to shift.
Mhm.
And then all of a sudden, this physician or this referring provider is like, oh, you know what? I think I'm going to start including this on all my discharge
Right.
paperwork, and so yeah, so really using the tools that we have, just incorporating it, doing it now, and then making people know that we have a seat at this table.
Yeah, I love that. I think the first thing is we have to shift our thinking,
Yes.
right? Of like,
Mhm,
we are including the woman who just gave birth into this process.
mhm,
And that she is recovering from, again, surgery or
mhm.
a delivery, um, a non-surgical delivery
Right.
that might have had an episiotomy. So there's
Right.
layers here,
Right, of
right?
course.
And it could have been a very long delivery. We forgot about there's a whole time involved with this too. And before that, there was 9 months, and we don't even know what was going on during those 9 months.
Exactly.
But
Mhm,
so that shift of the mind, and then you're saying advocate and remember who your audience is, right? And so you're like, I love how you said just informally advocate and say, did you know we could do this? This is
mhm,
what we would do. We would help the safety of the mother. We can do that occupational analysis and say, we can teach them proper body mechanics. We can help with the pain. We can help with the environment, and we can help them be safe at home and heal better and be more effective in their role and take care of baby in a way
mhm.
that's really going to be meaningful for them instead of fearful or scary. And then
Definitely.
I like how you said it's stuff we know how to do. I know how to
Right.
teach log rolling. Just
Right.
because C-section,
Mm.
surgery is not any different than we teach log rolling for any other
Mhm.
condition, right?
Yeah. Mhm.
We know how to do that.
Yeah.
Um, cueing safe handling, like you said, while holding the baby,
Yeah.
we can do that.
Yeah. You
We
can do
can
it.
help with positioning, we do that.
Mhm.
We can help with step stools, we can
We
help with energy
we can.
conversation, and breath mechanics. So I just wanna reiterate, we can do this,
Mhm,
and we have the knowledge, we have the expertise, we can do this, and we need to be doing this because
mhm.
we might be the only person
That is.
available to do it.
Mhm. Definitely.
Yeah, and it's,
Yeah.
you know, again, it's opening up opportunities for us.
Oh, yeah.
It's opening up, I always say monetize our magic. It's opening up so
Mhm.
many things. I'm hoping right now people are listening and going, at minimum, I'm going to change how I do my everyday practice, but who knows? Maybe we start getting some really cool emerging practice areas that
Yeah,
come out of this, right?
definitely, definitely.
So I love this advice. And one of the things, as we wind down, I
Mhm,
love to kind of I would like to have you talk about this from I'm a peds therapist, I'm walking in the room, and just tell us a story of
mhm,
how you would go about, a case example with Sarah. If you were walking in, I know you said you're not an EI peds
yeah,
therapist, but
right.
you're going to play one today,
Okay.
and how you would, or maybe Melissa,
Mhm.
whoever you're going to see, um, how would you help her?
Yeah. Definitely. All right. So I will put on my EI hat for the day. So yeah, so we'll Sarah, Melissa, we'll go with Melissa. so you've received or I've received a referral to see a 1 month old baby, right? So
Mhm,
4 weeks out, and maybe the referral says that there are tone concerns
mhm,
and feeding concerns. Okay. So it's pretty straightforward. I've been a practicing therapist for 12 years. And so I've already, even before talking to Melissa, or, I looked at the chart, but I'm like, you know what? I sort of have an idea of what this might look like. Like I have already formed sort of that tentative plan. We all do it, right? Like we sort of
Right.
have an idea. We change it up, obviously, once we meet, but we have an idea of what this might look like. But, now you listen to this podcast, and so you've had a mindset shift, right? And so from the moment you step into that home, you start to look and say, you know what? Melissa looks like she might not be 100% okay, right? So, you
Mhm.
know, maybe before the podcast, would have been more focused, hyper focused on baby, but now you're noticing that, as she's showing me how she holds baby to feed, she's wincing or she's grimacing every time she turns or she shifts, right? And she's sitting in the couch, but she's really like slouched and just it just looks real uncomfortable. And I can see maybe what baby's struggling with, but then I'm also like, well, this also just doesn't look that great. And then, so we're like, okay, now well, let's see how baby we're assessing tone, right? So now we're gonna put baby on the changing table on the bed, just to sort of do some things and see. And we notice that she goes to stand up from the couch, and then all of a sudden she's like one hand is down and she's sort of clutching, that surgical incision, and you're like, wait, okay. And so you decide, I listened to this podcast. Nicole and Zesarae said I should just ask the questions, and so you do, right? And she says, no one's asked me this question before. She's
Right.
grateful, but she's like, all they said was just don't lift anything too heavy. Um, so
Right.
you see this, you say this, so you're like, okay, well, you know what, I might be able to help. So not going outside of your scope of practice, staying in your OT lane, but looking at, like, as I'm before I leave this first session, I want to talk to her about some things that might make this easier for her too. So it might be, maybe she would do better versus not sitting on the couch to feed, right? Maybe laying
Yeah.
in sideline with supported pillows might be less taxing on her body, right? So, or even if she didn't want to do that, if she didn't feel comfortable, then helping her use pillows to adjust on the couch, right?
Mhm.
You notice that she was clutching to stand. So teaching her to exhale, or cueing her to exhale before standing, to engage those abdominal muscles to support her a little bit more and reduce that pressure, right? So, bending over to put baby down on the bed for changing or on the changing table. So teaching that wider base of support, that wider stance, using that hip
Mhm.
hinge versus that back bending, right? And then
Mhm.
also providing language to her, or telling her some of the things that she can talk to her OB about. So,
Mhm.
and then telling her, maybe when you go, ask about the scar massage, or like, ask about what that might look like, or what tools they have that can facilitate that, right?
Mhm.
So again, before this podcast, you might even think that that's just normal, but we know that that's not normal for them to be experiencing that, right?
Right.
So we're now not just pediatric OTs, but now we're just perinatal OTs, right? By default, because we have to make sure that this co-occupation is done efficiently for the child that we're initially there to see, but we also know that we now need to protect mom as well.
Yeah, and I think the thing I'm gonna really cringe even asking this is or saying it is that we have to think about her lifting the carrier.
Oh, yeah. Well, yeah. Yeah.
'Cause that's heavy, and I see
Yeah,
moms out there, they're, like, carrying it with one hand, like,
I know.
"Yeah," like,
It's
from the
impressive.
trunk.
It's pretty impressive.
But, oh, man, like, I'm thinking about that. That's gonna be an important one to
Mhm.
tackle with them,
Yeah,
for
and
sure.
and yeah, so just again, having them show you the task, and because that's the thing, you can't assume what it looks like or what it should look like, because everybody's environment is different. Maybe someone's taking upstairs, maybe somebody isn't. So really having them show you the task too,
Mhm.
and then breaking it down and coming up with ideas with them that might help.
Yeah, and I think I'm gonna start telling moms, I'm gonna say, "You know what? You're the CEO of your caregiver system.
Yeah,
So
it's
bring these
true.
people in to help you
Mhm.
and have your
Delegate.
planning," right? We
Mhm.
love that idea of the plan,
No,
but
definitely.
yeah. So, okay, so to wind things up, I have one more question that, this has been really great talking about this, and I feel like we could just keep talking forever. I was saying that too on these other episodes about maternal health. But one more question. What do you think is the next frontier
Mhm.
in I know you're not a pediatric therapist, but in pediatric rehabilitation on this topic of maternal health? Even I know you're talking about physical, but just even
Right.
beyond, just maternal health in
Mhm.
general, that our listeners should be on the lookout for, or maybe they could be a part of it.
Yeah, I think, I would say two things. I mean, they're very similar. To me, it boils down to advocacy, and
Mhm.
that's advocating for them to be a part of that perinatal team. But then also for us, for our knowledge, for our comfort, advocating for OTs and OTAs to be educated on this in
Mhm. Yeah.
right? Like
Yes.
I, like, I don't think I ever heard anything about maternal health when I was in school. It's been a while.
I don't think so either.
Right. So maybe things have shifted a little bit. I'm not 100% sure. But yeah, so really I think the next thing is really advocating for this to be a part of our curriculums, because when it is, our future clinicians can advocate wider for us, right?
Mhm.
So really doing that, and because again, in order to have a healthy baby, you have to have a healthy mom, right? So it's we can't take one without the other.
If you change the game, you change lives, right? And that's what
Right.
we're here to do.
Yep,
Well,
definitely.
thank you so much,
Mhm.
Dr. Bodie. This has been amazing. That's all the time that we have for today. I want to thank you again for your
Mhm.
insight and for the practice related takeaways
Mhm.
focused on physical maternal health.
Thank you for having me.
Thank you for tuning into this episode of Pediatric Pioneers by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and complete the quiz for this episode. Pediatric Pioneers also listens to you. If there is a particular practitioner that you'd like to hear from, or if you have a question or challenge that you'd like to explore on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcast@medbridge.com.